Hopefully that is working for everyone. Very good. Okay, so thank you very much for the introduction, Rachel. My name is Amanda Winter and I am an in vitro diagnostics evaluation methodologist at the Newcastle MIC. And today I'm going to be talking primarily about how we consider some of the features of tests. Quite a lot of these are mathematical considerations, but I've tried to stay away from maths as much as I possibly can in this presentation to try and make it a bit more accessible to everyone. So the first thing that I kind of want to discuss or think about is essentially what is a medical test and how can we use them. So to address what is a medical test, so medical tests can help us to detect a condition. It can help to determine a diagnosis, can help to plan treatment. It can help to check to see if a treatment's working or monitor a condition over time. So you can see that there are a few different ways that we can use those. And there are four major groups of ways that you can use a test. And some of these you might be familiar with and other ways you might not be so. But the first one I want to talk about is screening tests. So screening tests are using a medical test to find unrecognised disease in apparently healthy or asymptomatic patients, which means people who don't have any symptoms of a disease or a condition. An example of this type of test would be things like the bowel cancer screening program, or cervical cancer screening programs, which are aimed at people who don't have any signs or symptoms of these conditions, but are a nationalised program. And then we move into the diagnostic tests, which Rachel did describe in a bit of detail in her introductory slides there, and that's largely where the majority of our work lies. But a diagnostic test is a medical test that we perform to aid the diagnosis when the disease is actually suspected in the first place. So an example would be going to a GP with symptoms of, for example, liver disease, and a doctor would order a liver function test in order to help them either confirm that diagnosis or to help them decide to look for a different cause. So diagnostic tests are in somebody who we have suspicion already. And then the third category that we can think about is prognostic testing. So prognostic tests, these are a type of tests which help us to identify or categorise people into different levels of risk for different types of future outcome. So for example, a person who's already been diagnosed with a cancer might have some genetic tests to decide whether they're at high risk of having a complication or that their disease might progress quickly. And this type of test is a prognostic. And then the final and fourth category that we can think about is a monitoring test. And these tests are tests to keep track of response to treatment or to keep tabs on a disease progress. So an example of this would be blood glucose monitoring in patients or people with diabetes, which Rachel mentioned that example, or for example, therapeutic drug monitoring for people who are having chemotherapy or immunosuppressives or other drugs like that. So primarily today, what I'm going to be talking about is largely concerned with screening and diagnostic more so, and we're going to kind of ignore prognostic and monitoring testing for today, but just to make you aware that they do exist. So the perfect test. If we had a perfect test for something, what would it look like? So I've shown 100 little people here. Get familiar with them because they're going to be cropping up over the next set of slide decks. So introduce yourselves. I haven't given them all names, but there's probably the ones that crop up later in mind. So if we had a perfect test, the perfect test would tell us whether somebody does not or does have the condition or the disease that we're interested in, with absolutely no error. It would get it right all of the time, and it would perfectly categorize those patients. And sometimes methodologists like me refer to this kind of test as the gold standard test. So a gold standard test can be a perfect test, or more realistically, a gold standard test is the best available diagnostic test that we have for determining whether somebody does or does not have the disease. I can't think of many perfect tests off the top of my head. They're quite unusual. So bearing in mind that we live in an imperfect world and we don't actually have many tests which are perfect tests, the tests we do have available sometimes miscategorize patients, and I'm going to discuss that next. So because we can't always perfectly get a 100% accurate answer, we therefore need to think about all the possible outcomes that we can get from imperfect tests. So to do this, we use this, what's called a 2x2 table, and this describes the two possibilities for the patient, that they either have the disease or they don't, and they're healthy. So that's in the top row there. And then there's two possibilities of the outcome of the test. It's either a positive test or it's a negative test. And we can use this table to think about the 4 possible outcomes that could come out of those combinations of having the disease, not having the disease, having a positive test, having a negative test. This table is sometimes called a confusion matrix, and you might see why at some point during this presentation. So the first possibility that we can have is the patient does have the disease and they have a positive test. So this is what we would refer to as a true positive. The test has correctly identified that person as having the disease. The second possibility is that the patient does have the disease, but the test is negative, and we call this a false negative. So that's an incorrect test result. And then the third possibility that we have is the patient doesn't have anything wrong with them, doesn't have the condition, but they have a positive test, which is a false positive. And then the final possible outcome is that the patient is healthy and they have a negative test. So that's a true negative. So you can see in that 2x2 table, of those 4 possible outcomes, 2 are correct and 2 are incorrect. And we have ways of describing these 2 populations in these columns. So the diseased patients, or patients who do have the condition, the characteristic of the test that describes this column is called sensitivity. And the term that describes the characteristics of the test in these patients is called specificity. Now, whoever came up with these terms made them confusingly similar. I don't know whether they did that on purpose, because it still trips up even those of us who work in the field. So if I get them the wrong way around, I do apologise in advance. So we can look at those in a little bit more detail. So when we talk about sensitivity, we mean how often a test correctly gives a positive result for those who do have the condition. And they're expressed as percentages. So when we say a test has a 90% sensitivity, this is what we mean. We mean we have our 100 people here, they're back again, and that 90 of those will be true positives. We will have correctly identified that. And then 10 of those will be false negatives. So we have 90 and 10, which is the 100. So that's how we describe those. Now the converse of that, and I have just made these percentages up, they don't mean anything, they were just a simplified, they're just a way to explain without using decimal points and so on and so forth, what we mean. The reverse of that, or the kind of other column, is specificity, and that's how often a test correctly gives a negative result for those who do not have the condition. And again, we're not very inventive. They are also expressed as percentages. And I've given an example here of a specificity of 80%. And here's our crowd back. So this time, these are the true negatives. 80% of them are true negatives. We've got correct. And then 20% there are false positives. So you can see how we derive that number from. So that's a bit of maths, and I'm not a great fan, so we'll move swiftly on. So what do those numbers and what do those terms actually mean for a patient or a person who's receiving that result? So for true positives, this means that the condition or the disease will be correctly diagnosed and they can receive treatment for that disease or condition. A true negative result, they might be correctly given a clean bill of health, or the other causes of symptoms or signs can be investigated, because we're now not looking for the thing that we've tested for. The false positives, so being incorrectly told that they have a disease or condition, or there may be a disease or condition, can lead to people undergoing unnecessary treatment or unnecessary further tests. And a false negative result means that they're incorrectly told that they don't have the disease, and therefore can be falsely reassured, amongst other consequences. So, because we're talking about COVID today and COVID-19, there's some special considerations for incorrect results of COVID-19 tests. These aren't the case for all diagnostic tests. These are just ones that I've put on here because they're specifically about the disease of interest. So having a false positive result means that a person might be incorrectly told that they have COVID. And this can result in potential accidental exposure to true positive cases, for example, in hospital through cohorting on wards or so on and so forth, and then possible delay or cancellation of appointments and procedures because of that false positive result, and also having to self-isolate unnecessarily on the basis of that result. And then for false negatives, which mean that they're incorrectly told that they don't have COVID, and then the consequences of that are that that person might not appropriately isolate, or probably won't appropriately isolate at home or in hospital, and can go on to infect others. And that might also cause potential delay in seeking repeat testing or seeking more help if the symptoms worsen. So there's special considerations that don't apply to all tests, but do apply to some COVID tests. It's important I think to just point out here that the false positives for COVID testing are considerably lower than the false negatives. So the first set of potential outcomes there of those results are far fewer than the false negatives. So I appear to have a circle drawn on my screen. I don't know what's happened there, but so causes of incorrect results in COVID testing. So I'll go through the false positives first. So some of the potential causes of false positives are interfering reactions in the test, and this is sometimes what we call cross-reactivity, and this is where potentially other viruses or other contaminants in the sample cause a false positive result. Or we can potentially get contamination of the test during the sampling phase, so when the test's being taken, or during the lab processes, and these are actually relatively unusual occurrences. The tests are designed in such a way, and the processes are designed in such a way that these kind of errors are actually minimised. That's not to say that they don't happen at all, but they are much less usual than the false negatives. And the causes of false negatives are poor or suboptimal sampling technique, samples that have gone off because they've been under transport for too long, or it's been too cold or too hot, which can degrade the sample and mean the test doesn't work very well. And also taking samples too early or taking samples too late in the disease process. So there's an optimal time to get a COVID-19 swab test, and that's between 1 and 6 days post-symptom onset. So it's not to say that getting the correct result outside of that time frame is not possible. It just makes the likelihood of false negatives much higher than if the test had been conducted in that window. So back to our 2x2 table. We find actually that a much more helpful way to understand what tests mean to a clinician, to a doctor in a clinic, is to think about the tests in a kind of real life scenario. And to do this, we use something that's called predictive values. So because when we talked about sensitivity and specificity, we were looking at really what would happen in a compared to a perfect scenario where we knew the outcomes. But in real life, we don't tend to know that. What we have to base our assumptions on is the rows rather than the columns. So a positive predictive value is the likelihood, if the test is positive, that the person really does have the disease, and that represents the positive test row. So true positives and false positives are taken into account, and that gives us a positive predictive value. And then the negative predictive value is the negative test row. So taking into account the false negatives and the true negatives, if the test is negative, how likely is it that the patient really doesn't have the disease? And we call these positive predictive values negative predictive values. And these really help us to understand the real life performance of tests, but they are critically dependent on something that we call prevalence. And prevalence is the number of people in a population which have the disease at a particular time point. And I'll try and describe what this means for our tests in the next slides. Well, here's our people, they're back again. So we have our 100 people, and this is a high prevalence scenario. So a lot of people in the population have the disease that we're interested in. And I just picked the figures from the 90 and 80% that we were talking about earlier. Completely made up. They don't mean anything in particular. They're just nice round numbers. So if we tested every single one of these 100 people for the disease with our test, which we were talking about earlier, the people who would have a positive test would be 9 people who really do have the disease, and 18 people who we've got a positive result for that don't have the disease. And those people altogether, so basically there's a third chance that they're going to be positive. And then the people who had the negative test, which is the rest of them, this is one person who we missed, and then all the rest were correctly identified, the dark blue people. So you can see that this test on a high prevalence population does a reasonable job of differentiating. We've got most of the people, although we've generated some false positives. We've told most people that they don't have the disease, but the test has missed one person. That is reasonable. So that's how it performs in a high prevalence situation. Now, if we change the prevalence and people back, but this time, instead of having 10 out of every 100 people in our population who do have the disease, we've now only got one person in that population who has the disease. The test is exactly the same. Nothing has changed about it. It still performs in terms of sensitivity and specificity exactly the same. But now you can see that the amount of positives that are generated for finding that one person are greatly increased. Numerically, they might be very similar, but instead of having a 1 in 3 chance of the person who has a positive test being actually positive, it's now down to only about 4%. So you can see that the rate of false positives to true positives has really gone up. But you can see in the low prevalence situation that actually this test is a really good predictor of somebody being negative. If they've got a negative test, there's almost no chance that they've got the disease at all. So really, when we think about how we deploy tests, if you think about those scenarios that I mentioned right at the very beginning of screening and diagnosis, you can imagine that the prevalence or the amount of people who are in this top left corner increases or decreases depending on which situation that is. Screening's relatively low prevalence, diagnostic maybe still low prevalence, but the prevalence can change within that depending on what symptoms the patient has, or so on and so forth. And you can see that that really affects how the test performs in real life. So what does this mean for a patient? So like I said, the same test will perform differently when the prevalence of the disease that it's testing for changes. And like I said, in our fictional example, to find that one case, we had to generate 20 false positives as a result of that. Now, sometimes we can accept this and sometimes we can't accept this. And that really does depend on what the consequences of the false positives and the false negatives are. Sometimes if a false positive has very low consequence, then it might be acceptable. But if a false positive, for example, results in somebody having surgery under general anaesthetic, then a false positive is really a big deal. And really what we are trying to do is understand how those harms and benefits should be traded off. What do these mean for evaluating our COVID-19 tests? And I've touched on some of these, but trying to assess test accuracy where there is no gold standard can be quite challenging. I mentioned earlier that you have to calculate sensitivity and specificity against your gold standard. But when we don't really understand or have a proper understanding, particularly at the beginning of this pandemic, what the gold standard is, that can be really difficult. And we do a lot of work on tests, not just in COVID, but in other diagnostics where there is no gold standard to compare the accuracy of our tests to. So we have to use a variety of different methods to try and construct a standard. And another problem with COVID-19 testing, as you can see, and I've just mentioned in when we were talking about prevalence and predictive values, is the prevalence of COVID-19 keeps changing. As you can see from that graph at the bottom, we had a big spike in April and then it went down over the summer, and now we're seeing increased incidence of cases again. I've put a question mark there because we don't know, of course, what the future holds, and this change in prevalence keeps changing how we assess the benefits and harms that we're assessing. So finally, just to kind of conclude what I've been talking about, and I hope everybody was following along okay there. There are consequences, both good and bad, to all testing, not just COVID-19 testing, but all diagnostic tests. And what we really try and do by doing our care pathway analysis and our economic analyses is to understand where and how a test will be used to assess its performance, because as we're seeing, that's actually critical to understanding how a test performs, not just in isolation, it's within its context. And also understanding, like I said, how the changes in these levels and in these statistics equate to benefits and harms of doing tests, and how that's important to acceptability both for clinicians, patients, health economists, and so on and so forth. So I think that's me. I don't think I've run over time, and I hope there's some questions that are that I can answer, hopefully.
Thanks, Amanda. Hello, everyone. I'm Kasia Korowska, the PPIE manager for the MIC. And so, Amanda, would you be able to close your slides off so we can see everyone's lovely faces?
Certainly can.
We've only got a couple of minutes for questions, but there's one that came in the chat from Louise on the graph that you showed near the end. Does the prevalence on the graph include false positives?
That's a good question. So full disclosure, I made that graph up. It just follows loosely the trend of prevalence. But since the tracking of COVID-19 in the UK does include positive tests, yes, it will include false positive tests. But most of the time we don't know that they're false positives.
Okay, great. Now it said 2 people had raised their hands. I'm gonna depart from the technical stuff and ask if anyone would like to raise a question. Could they physically raise their hand? We'll just go old school and use our hands, because I think, and you'll have to bet. Jeff Hammond.
Hi everyone. My question is, a negative test is only going to be valid in the case of COVID for a short period. So how does that affect the feasibility and the economics of mass testing?
That's a really, really good question and an interesting question. Full disclosure again, I'm not a health economist, but my initial thought is that yes, it definitely does have an impact on the economics of doing testing, because like you say, the result validity is only for a short period of time, so that would mean that you would have to do extensive repeated testing, and I would think that unless the test is relatively cheap to administer, that may be economically unviable, but you would have to build a full model in order to assess that.
Okay, thanks, Amanda. There's one more question. I can see that Ian Davey has been very clever and actually used the tech to raise his hand. Ian, would you like to ask your question?
Thank you. The question is about, is it natural to think that false positives are better than false negatives?
Yeah, that's a really good question. I think in a pandemic situation, the temptation is to believe that the false positives are better than a false negative. And I think particularly with the types of tests that we've been using, the false positives are actually relatively unusual. So they don't tend to cause the same level of concern as having a false negative. Particularly since we see in this situation, the consequence of a false negative is potential additional spread of the virus, and that's obviously thought of as quite a concern. So yes, I think false negatives are seen in this scenario as being worse than false positives.
Thanks,
Thank you.